Welcome to our special panel on fertility treatments and breastfeeding, brought to you for Canadian Fertility Awareness Week. Today, we're joined by Sara, a newer Leche League Canada leader living in Victoria, BC, Michaela, a mom from Ontario, here to share her experience, and Dr. Sharma is a fertility doctor at CReATe Fertility in Toronto, Ontario. Sara reached out to share this discussion in hopes of supporting others navigating similar journeys. We know that every family's path is different, and the intersection of fertility treatment and breastfeeding is rarely straightforward. As a gentle reminder, Leche League Canada doesn't provide medical advice or replace the guidance of your healthcare provider. Our goal here is to share experiences, offer resources, and create a space where you can find information and community. Take what resonates, leave what doesn't, and know you're not alone in this journey. We hope this conversation helps you feel seen, supported, and more prepared wherever your path may lead.
Thanks so much, Nikki. I was so happy that we were able to organize this, and I'll start by introducing myself and then have Michaela and Dr. Sharma introduce themselves. So I'm Sara. I use the pronouns she, her. As Nikki mentioned, I'm living near Victoria, British Columbia, but did my most of my fertility treatments while I was living in Toronto. And so yeah, I live here with my husband, Andre, and our two children. I went through 4 years of infertility with multiple rounds of IVF and 2 pregnancy losses before we welcomed our first child earthside. And then in a little bit, I'll talk about my experience breastfeeding and doing fertility treatments, but we did have a successful embryo transfer to have another child when my toddler was around 18 months. Obviously the process takes a little bit of time. So I'll leave it at that for now and pass it over to Michaela to introduce yourself.
Thanks, Sara. Hi, I'm Michaela, pronouns she, her. I live in Ontario, Canada, and I have a wife and 2 children, 1-year-old and 3-year-old boys. And I did my fertility treatments mostly in Toronto at Mount Sinai Fertility there. And we did reciprocal IVF. So my wife did an egg retrieval and I carried, and then I did an egg retrieval and I carried my own egg the second time. So in that time frame, I was breastfeeding my older son and continued to throughout the retrieval, the transfer, and some of the pregnancy. So I'll be talking a little bit more about that.
Great. And then Dr. Sharma.
Hi, everyone. Well, thank you so much for inviting me to this informative conversation. I feel like I'm also going to learn some things from the personal patient experience. So I'm excited to hear all of the discussion. I'm Dr. CReATe Sharma, pronouns she, her as well. I'm a fertility doctor who's been practicing here in Toronto for the last 15 years. And, I hate to age myself, but I think in 15 years of practice, because this is a relatively new field, so many things have evolved and changed. And I think the big thing is whether it's regarding breastfeeding and frozen transfer, breastfeeding and IVF, or any of the other things that are sort of not quite black and white. I think it's important to have some flexibility and to think about what can improve the patient experience and patient journey without compromising success rates. And it's all about disclosure. And so when I talk to my patients about this particular topic, and interestingly enough, the last patient I was seeing and running to get to you guys was a patient who was breastfeeding and thinking about baby number 2 and in the process of weaning, and sort of she was struggling to decide, do I continue to breastfeed and do a different protocol than I did the first time? I only have 1 embryo left, or do I stick with what worked? And so I think it's all about just being really transparent and having an open discussion with the patient. There's no absolutely one perfect choice. And so I guess rather than, quoting my degrees and my years of experience and all that, I'd like to say that my evolution as a fertility doctor has really been to maximize the patient journey and to make it really collaborative. So I think this is a great topic to talk about when it comes to that.
Yeah, thanks so much for mentioning that. And I should Happy to be transparent that Dr. Sharma was my fertility doctor. And so we work together and can really attest to that like collaborative nature of the experience and the journey. And Dr. Sharma was my physician when we had our second pregnancy loss, and when I had the embryo transfer in pregnancy for our daughter, who was 3.5. And then we had moved, but Dr. Sharma still collaborated with us as we were deciding whether to kind of like continue with breastfeeding, what protocol to use, and then working with one of her colleagues who's out here in BC. So yeah, I remember kind of at first thinking, oh, we always have to wean, right? And I think that's the first question that really comes up for everyone is like, do I have to wean to do fertility treatments? And that can vary as much as, IUI, like even medicated cycle, IUI, IVF, whether we're talking egg retrieval or an embryo transfer. I think this question even comes up for people who aren't pursuing fertility treatments, but just trying to get their cycle back, regain their fertility after when being postpartum. So, we're here talking about our experiences, but maybe we start with Dr. Sharma. When someone comes to you and says, do I have to wean? What are the options for sort of like pursuing fertility treatments while I'm still breastfeeding?
Yeah, so totally. This is a great question. I think if you look at the textbooks and, go back to the things that nobody ever opens, you can see that big shelf in back of me. All of those books say we like patients to wean 2 cycles before you do anything because of the elevated prolactin levels and what that effect could be. But that teaching has changed. The one thing I will say is we do like you to have some element of your cycles back. Now, there's a caveat to that because patients who are anovulatory from PCOS, they have another reason for not ovulating. But in those patients that are completely suppressed because they're breastfeeding, let's say, every 3 hours throughout the day, 24/7, their hormone levels and their gonadotropins are going to be so unbelievably low that they're not going to ovulate no matter what you give them because they have super, super high prolactin levels. And we know when you're breastfeeding every 3 hours throughout the day and night, it's a contraceptive. You can't get pregnant. So we do like some element of weaning where the hormone levels, the gonadotropin levels, and the estrogen levels are sort of somewhat normalized, because then we can tweak that and work with it a bit. And so that's the first caveat. So in general, with my patients who are ovulatory, I'll say, okay, well, are you weaned enough that you're getting your satisfaction from breastfeeding, but you're cycling? And if you're cycling within some element, you can try naturally, you can do IUI, you can even consider medicated IUI. And if you're in the IVF boat, you can certainly try gonadotropin stimulation for IVF or FET. I will say most of my experience with patients is from trying naturally, doing IUI, doing medicated IUI, or doing FET. I actually haven't had the experience of stimulating someone while they've been breastfeeding. And maybe that's just because most of my patients have done their IVF like when they're in a naive state and they don't have a pregnancy and they have extra frozen embryos to transfer. So I haven't had that. So I'm so interested to hear your experience. So I would say the dogma has changed. Like historically, we were worried about the effect on the mom and baby. Oh, you're taking all these hormones, and what is the risk of these medications passing to your child? But the truth of the matter is there's very little passage of these medications into the breast milk and very little risk. The biggest risk that I talk to patients about is that you could diminish the quality and amount of your breast milk. I think that's really the biggest risk. So when I talk about it, if you're on estrogen for an FET preparation, it's relatively high doses of estrogen. So taking those levels of estrogen is going to diminish the quality of your breast milk. And like that's important to know. So I tend to favor natural FETs or modified natural FETs in the breastfeeding population because then that risk is lower. With regards to gonadotropin stimulation during IVF, same possibility that as your estrogen levels go up, potentially it could suppress your breast milk. And so there are ways of keeping the estrogen low. We have lots of tricks in our toolbox to do that, and perhaps that could make things more effective. And then the third thing I'll say is, depending on how the baseline levels of prolactin are, even if you are breastfeeding, I use that as a little bit of a gauge. And it might not be completely scientific, but people who have really, really high prolactin levels, it could affect implantation rates, because high levels of prolactin can cause a luteal phase defect. Now, we do supplement with progesterone, so the question of where is that balance, it's hard to say. But again, this is where the conversation with patients is really important. If you have one embryo left, you might not want to play around and just, go for it. You might say, I'm going to just wean and not worry about it. If you have multiple embryos, you can certainly try. And I have plenty of patients in my practice who've had all of their babies while breastfeeding, like literally like one after the other. They just come back for their FET and they breastfeed throughout. So I think there's a lot of flexibility here. And I feel like I answered this question much more deeply than I should have. So apologies for that.
No, that's awesome. That's great. And I think, one thing that I think comes up with all of this, and as you're talking about sort of like that weaning process and the amounts of the level of prolactin, is we often talk about sort of that spacing also of pregnancies, right? So once and I think both Michaela and I will speak to our experiences of this, but we were breastfeeding toddlers, right? This was over the age of 12 months, and even a little bit further than that, kind of depending. And so to sort of address the piece around the hormone levels and also the decrease in milk supply, right? So that if it's before 12 months, I think the one thing that we also, consider and have to keep in mind is fertility treatments and also a subsequent pregnancy, if that's kind of where we're going with an embryo transfer, IUI, whatever it is, all have the ability to decrease milk supply for many, many people. Not everyone. Some are kind of those lucky folks who keep having lots of milk throughout a pregnancy, but most people will see a decrease. And so if we're talking about, before 12 months of age, well, then there's a consideration of what are we supplementing for that child who needs, who's kind of like needs a certain amount of milk, however, until 12 months. And then after that, there still is the consideration of, maybe not supplementing in the same kind of way, but with more solid foods, with, perhaps a reduction that will impact, their emotional regulation and their sleep patterns and like different things, as we, continue to go through that weaning process that really starts when we start feeding solid foods to our kids. So yeah, I think that's
along that line. I should mention one more thing, which is interpregnancy interval. And so, yes, along the lines of what you were talking about with you both had toddlers. I mean, listen, like if we wanted, we could put a frozen embryo in 2 months after you pop out a baby too, right? But the data shows that ideally the interpregnancy interval should be 18 months, which is from the start of your first pregnancy to the start of your next pregnancy. So safety is also key, especially if you've had a C-section. You want time for that uterus to heal. So at least 6 months is important. So the timing is also crucial and key for other reasons.
Yeah, and that's great, right? And I think it all has that interplay with, again, talking with your care team and kind of making those decisions. So maybe we'll talk a little bit about our experiences and how we kind of decided to keep going. And so maybe I'll start a little bit with mine, and then, or actually, Michaela, are you comfortable going first? Because I feel like you have like that different experience of the egg retrieval.
Sure. I'm happy to go in any order. It's totally fine.
So if you want to talk about sort of as you were thinking about, doing an egg retrieval and talking to your care team and kind of making those decisions, and then your experience of that.
Okay. Yeah. So we obviously did the egg retrieval for my wife first, and then I carried our son, and we knew that the process takes longer than you expect. I think that's just sort of the nature of it. So when I was at the end of my pregnancy with our older son, I had reached out to our fertility clinic to just get back on the wait list to kind of like start talking again about a second child. We knew we wanted to have another child, and we weren't sure, because we were using my eggs, if we were going to do an IUI or an egg retrieval. It was kind of like, it depended on what we felt made the most sense, I guess, at the time. So when my older son was 8 weeks old, maybe, we had an appointment with our fertility doctor, and I had asked about, I was under the impression I would have to wean before we did any treatment. So I was kind of trying to plan that, like making sure it would be at least after the 12-month mark if we could. And so when I was talking to her about that, she had said, like, actually, I don't think you have to wean if you don't want to. This is obviously like way far in the future at that point because I had a 2-month-old. But she said if it's not something you want to do, you don't actually have to do that. We can figure out a way to kind of adapt the meds so that it's safe for you to continue breastfeeding. I really liked hearing that because it was like, again, in the fertility world, I think we're constantly thinking like 3 steps ahead. We're always like wondering what we need to be doing to prepare for the next thing. And so it was such a relief to hear that, whether or not he was still breastfeeding at that point, like I wouldn't have even known, of course, but to not have to be thinking about, like, I was like trying to pump extra to have more of a stash in case I needed it down the line. And of course, like when you're a new mom, there's so many things that are on your mind that like one less burden feels really good to have off your plate. So hearing that was a big relief. And then we were doing a funded cycle. So our funding came up in I think it was October 2022. So my son was actually 10 months. He would have been 10 months at the time. So he was still young. But we also had to like kind of take our funding when it came. So we couldn't really like put it off. So again, I talked to my doctor about it. She was okay with moving forward. He wasn't like a huge comfort nurser. So he was probably nursing about 3 times a day at that point at 10 months, which made it a little bit easier. Like he wasn't relying on me too much for milk. And if my supply dipped, I felt comfortable enough that he was getting like lots of solids and he was like on HOMO milk at that time. I wasn't so concerned. So yeah, we went forward. The only thing I can remember off the top of my head that my doctor had said we would need to like change is that I didn't do any estrogen priming for that cycle. And again, my case might be a little bit different because we were doing fertility treatments because we were a same-sex couple. There wasn't any like medical reason that we know that I would need fertility treatments. So I think we could be a little bit more flexible in some ways. Oh, you can't hear me? Can you hear me? You can? Okay. Dr. Sharma, you can't hear me? No. Weird.
You can't hear
But
me.
you can hear Sara? Yeah, Nikki,
Yes.
you can hear me?
Can you hear me?
Yeah.
Yes.
But we can't hear Dr. Sharma.
Yeah.
Maybe. Let me just add that.
Okay.
Oh, maybe the headset.
Yeah, maybe the headset died.
Hello?
Yes.
There we
There you
go.
go.
Okay, I don't know. Maybe it lost charge for a second. I thought it was yours. I apologize.
No,
That's okay.
That's okay.
Thank
We're
you.
glad
Hopefully it'll be okay.
Yeah,
Great.
that's totally fine.
So you were
yes.
saying, Michaela, you could be a bit flexible. Just, the reason you were doing this egg retrieval or, restarting fertility.
Yeah, in some ways we could be a little bit more flexible. Obviously, like we still wanted it to really work. We didn't want to do anything that would compromise the outcome of the retrieval. But because at the time I was 29 and with no like formal diagnosis of anything that would kind of complicate things, it was a little bit easier for me to be like, yeah, let's try to like see what we can do. And I want to continue breastfeeding. That felt like something that was also important to me. One, because of my older son's age, like he wasn't even at that 12-month mark. And two, just it felt like it gave me a little bit more control. And I know anybody who's like done fertility treatment has probably felt that there's a lot of loss of control in the process. So it was nice to be able to keep something that felt like consistent in my schedule, consistent for the baby, and then also just like a way that I was still like sort of in control of my body and the things that I got to do with it. So that was really important to me. I think also at the back of my mind, there was part of me that was like, if this is totally unsuccessful, if for whatever reason we don't end up with a baby at the end of this, I would want to have kept breastfeeding my son for longer if that was possible. Like that, I think it would have been more devastating if I had to stop and wean. And then also, for whatever reason, we didn't end up with a second child. Of course, that was like our hope and our goal, and we would have worked really hard to get there, but we also can only control so many things. So that piece was also important, I think, emotionally, to have just to have known that I didn't have to sacrifice that part of our relationship in order to go through this sibling cycle. So yeah, I don't remember even what meds I was on. I think they were pretty standard. I think they were pretty similar to the same ones my wife was on, other than that we didn't do any estrogen priming. And then did the egg retrieval. I think that we ended up with 19 eggs and then 8 embryos at the end. So it felt like it went as well as it probably could have. I don't imagine that there would have been like really different results had we had like done anything differently, or if I wasn't breastfeeding. So yeah, that felt good that I was able to continue on and then have these results. I was part of a research study on a trigger shot, so I couldn't do a fresh transfer because the trigger shot was I don't know, it was something about reducing the chances of OHSS, if that's the right acronym. Okay. Yeah. So anyways, I ended up doing a transfer the next cycle, which wasn't actually part of the initial plan, but we just kind of got excited. We were going to wait a few more cycles and a little bit longer, but I don't know. Once we were in it, we were like, well, let's just go ahead. With my older son, I had gotten pregnant with a natural cycle. And so, with progesterone support as well in a trigger shot, but yes, a natural cycle essentially. So we're going to do that again anyways, which I know Dr. Sharma, you said that's what you typically recommend when you're breastfeeding. So that worked out well, that we knew it worked for my body. And then that was one of the protocols that is okay for breastfeeding. So I did a natural cycle the following cycle. So my son would have just been like, I think he was maybe turning 12 months the next week. And that one worked. It was successful. I got pregnant. But shortly into that pregnancy, we started to notice some abnormalities in ultrasounds, and it turned out that baby had a genetic condition. Our embryos weren't tested. So yeah, it was a really heartbreaking time. We ended up having to terminate at 13 weeks, and I was continuing to breastfeed throughout this time. So I breastfed up until that point, and had a DNC. And then we started to try again 2 cycles later, once things had kind of stabilized again. And I continued to breastfeed all through that point too. And again, I think that was really important for me to just feel like I had some control over what was happening in my body, that I was still getting to have this connection with my older son, despite the fact that it felt like so many things were not going well. Yeah, like having that connection and that piece with him was really important. So then we transferred again 2 cycles later, which was a chemical pregnancy. Then we transferred again the next cycle, and then that resulted in my younger son. Now, I continued to breastfeed my older son until about like 8 weeks. But Sara, I know you were saying maybe not to go into weaning too much yet.
I mean, if you want to, yeah, just keep going about, you know, if you want to talk a little bit about how that went for you. Sure. Yeah.
Okay. Yeah. At that point, he was now 18 months old. So we were only nursing 1 time a day. And my morning sickness was just like, it was like all the time sickness. I was just really, really sick. And I had been for the previous pregnancy as well. And I just had gotten to a point where I was like, I don't think I can give anymore. Like, I'm so tired. I'm so depleted. I've been now, like, in the first trimester, it felt like for like 6 months. So I just got to the point where I was like, I don't think I can continue, because I'm like too sick to even get out of bed a lot of the mornings. And my partner was like lovely and so supportive of that. And she was like, yep, I think that this is really important that you start taking care of yourself. This has been like a long journey. So she just kind of shifted to taking over like the morning piece with him and his morning routine a little bit, so that I could have some space to myself and try to like take care of myself, as I was feeling very, very sick in the morning. So that was kind of what the weaning looked like. Of course, like, weaning comes with a lot of emotions in any situation, but I do really look back on that time and feel appreciative that I got to do it somewhat on my own terms. Obviously, I would have liked to do it without the morning sickness, but we got to 18 months, which was excellent. And it was like a choice that I made, because at the time it felt like it was the best thing for like our family. Yeah.
Thanks so much for sharing all of that. And, you know, we were connected and talking as you were going through these experiences, but I just want to say still today, you know, I'm still so sorry for your loss, and your losses, right? The other chemical pregnancy too. Those are such hard experiences. And as you say, I think a lot of people who, just in my experience, chatting with others who decide to continue nursing as they're going through treatment, there is a sense of that, as you said, you know, like not sacrificing the nursing relationship, or, you know, the things that's working well, with your child, with your body and all of that, while trying to do something that has such unknown and uncertainty around it. So I definitely, really relate to that. And that was part of things for me as well in my decision making around when we would try another cycle for a sibling. And so I'll maybe, go into my experience a little bit. We had done multiple IVF cycles, multiple egg retrievals, and had embryos, frozen embryos. And so when we were deciding on a sibling cycle and have another child, in the back of my mind was very much like, it took 4 years and you lost 2 pregnancies to have one. Like, if it takes another 4 years and who knows, or longer, I was really feeling that clock, tick. And it's funny because I feel like Michaela and I even have talked about this. But my experience breastfeeding my child, my now toddler, is really different. Like, at 18 months, she was still nursing like 5-6 times a day. And, so when it was a bit before that we were talking, thinking about the sibling cycle, she was still nursing like day and night. My cycle had returned though, around 14 months postpartum, but she was still nursing a lot, lots for comfort, for all her sleep. Like, it was just really a big part of her needs and our relationship. And I really felt like I didn't want to stop that to pursue a sibling cycle. And so one resource that really helped me, and I think this is something we can share when we share this video, is this fantastic Facebook group called, now I'm going to forget what it's called, but Breastfeeding Moms Undergoing IVF, I think is called. And people share their experiences, but also wonderful moderators have kind of a spreadsheet with people saying, this is a clinic that was supportive of, my, continuing nursing, or people have kind of collated people's experiences in their information. And also they have resources towards kind of the more medical, medication and stuff, just to help people have conversations with their care providers. And so I found out about that group, started reading people's experiences, and was like, oh, like, maybe I can explore this. And so we had moved across the country. We were now, near Victoria instead of Toronto. So I think, got in touch with Dr. Sharma. And I also got in touch with a clinic here, of course, because I was more so considering doing my embryo transfers here, which meant moving our embryos, getting our embryos on a plane, basically. And so, yeah, I got, care set up in Vancouver at the time, with Olive Fertility, found a provider who was supportive of me continuing to breastfeed, and also had that connection with Dr. Sharma. And so then we talked about the protocol and what that would look like. I had a heavily medicated protocol to have my daughter. I was taking so much estrogen. I had like lots of extra medications because we were really trying to sort of overcome these losses that had a bit of an unknown reason for them. And I'm still so grateful to Dr. Sharma for, having the possibility of doing this kind of cycle and helping us. But then we were sort of faced with, do we do all of that again, or do we not, right? Dr. Sharma, remember that. And in our case, we were so lucky to have a number of embryos. And I felt like we could kind of take the chance and see if it would be different. And so we did decide to do a modified natural protocol. And we decided to forego a lot of those extra medications that I had taken, like blood thinners and steroids and a few things. So we sort of had a combo of like, I had some of the steroids and not some of the other things, and a modified natural protocol. So, and I took birth control before, so I could kind of control a little bit of when the timing would happen. And, so yeah, it was a really collaborative effort, I felt. And within even the modified protocol, I did take Clomid, because I have kind of this borderline PCOS where I have cycles and ovulate, but often it can be really long cycles and whatnot. So there was kind of that, and a trigger shot with monitoring, and then progesterone support when we did the embryo transfer. And so yeah, I kept breastfeeding through that. I think for me, actually, some of the difficulty was going to my like appointments and doing these things while I was caring for my for my child, she was just on the edge of starting daycare. So when I was actually doing my treatment protocol, she wasn't in daycare yet. You know, as we know, a lot of the fertility appointments are like the early morning. You've got to like leave home. I was like driving to the clinic. My parents were here for a bit to help with that. And that was kind of tough because there was, for me, still a lot of that, like, okay, breastfeed her, then I'm gone, then I come back, then I nurse her to sleep, then, you know, even though she was a bit older. And then we, oh yes, and even for me, for my transfer, I had to leave Vancouver Island. So, you know, I'm on Vancouver Island. I had to take the ferry, go to Vancouver. And that day was the longest time my daughter and I had ever been apart. And so it was the longest time we had gone between breastfeeding, like nursing sessions and all of that. And I even remember kind of thinking, like, is she going to kind of be upset or mad at me when I get back? And she was like this happy little kid. And I got back from the transfer and taking the ferry. And, you know, right away, she was like, Mama, and milk. And we nursed. And it was lovely, you know. And I was so glad that we could kind of keep this consistency even throughout the uncertainty of it, and like just not knowing kind of how it would go and what would happen. And so it was a successful transfer and I got pregnant. And yeah, I was able to continue breastfeeding. I think for me, I found that my milk supply really started to decrease around 10 to 12 weeks of pregnancy, to the point where it was sort of, I think it had an impact also on my breastfeeding aversion. So for me, it started getting really painful. I was really lucky to not have nausea or morning sickness, but I was just like, my like skin would crawl, that I was like, oh, she needs to like get off. It was really difficult because for us, it was such a comfort to her. It was so easy and good for me. So yeah, it started being a real change to kind of set some gentle boundaries around like how long she could nurse, and you know, like, okay, we're going to take a pause, we're going to start back again after. And with the less and less milk, also kind of had like more and more frustration on my toddler's part around like not really being able to continue nursing and not getting the milk she wanted. So that was one place where my partner really stepped in and, you know, supporting my daughter to sleep a lot more. And we just sort of like had to shift a few things as that happened. And that's something that I think like I knew about, but I wish I had considered that piece a little bit more. Not that I would have made any, I wouldn't have made a different decision about continuing to nurse and starting my fertility treatment, but I think I would have mentally prepared myself a little more for that decrease in milk supply and what that meant for sort of, yes, like the weaning process, but also kind of the frustration and dysregulation of my child and myself. And one thing that really helped me with that was the book Adventures in Tandem Nursing. So I always recommend that book to people, whether they actually want to tandem nurse or not. But if they're considering becoming pregnant while they're still nursing, there's a whole section on that piece and on like, you know, breastfeeding aversions during pregnancy, and really it's because of the hormonal changes, right? So that can also happen while you're doing fertility treatments, whether you get pregnant or not. And some of those challenges and kind of like the reflection a bit more on like what you're going to do to prepare yourself and maybe your child. If they're a bit older, you're maybe reading weaning books, you're maybe just talking about it, and that whole piece. So I think for me, I wish I had read that book a little earlier just to kind of help me prepare. Yeah, so that was maybe the harder part about that. But I was just so glad to be able to continue, and continued until almost 20 weeks of pregnancy. And yeah, so my daughter, I think I was close to 20 weeks of pregnancy and she was close to like 19, 20 months when she finally like stopped breastfeeding. And I wondered if she would start up again and tandem nurse. I feel like we got some questions about, you know, tandem nursing after fertility treatments and everything. I don't think there's necessarily anything different that needs to be considered versus another, you know, pregnancy journey. And in my case, that didn't really come up. But yeah, so that was my experience with that.
Sara, you touched a little bit about, and Michaela as well, about your partners and the support systems that you had. Can you think of some ways that partners and support systems can help for those who are listening or watching right now? What are some things, if you are a support person, or if you are a system, an organization, or a doctor even, what are things that helped you? And I know that this is a very unique question because each of you might have something different, but I'm sure there's kind of an underlying theme.
Do you want to start, Michaela?
Sure. The things that come to mind for me, like the moments that I felt that I needed the most support, specifically for the egg retrieval, I became very like bloated and uncomfortable, which I think is pretty typical for people who are taking all those hormones and their eggs are growing. But it became difficult to like pick up my son physically and like bend over his crib and things like that. So actually having my wife there like physically to pick him up and like put him on me to nurse was really important. I needed that support, like at least for the last kind of few days, and then like a day after the retrieval, it was just like nice to have somebody there to kind of like do that lifting so that it wasn't, yeah, so it wasn't as painful for me. And then I think just having somebody who's kind of like witnessing your experience is really important. Somebody who's there and like in some ways is like cheering for you and rooting you on, and in some ways is like also kind of doing those check-ins like is this okay? Can you keep doing this? Is this feeling like too much? And that was really helpful for me, at least once we got to the point of weaning, like having my wife there to kind of say like, this has been a lot, like we don't have to keep going, and like I think that that can be really helpful at any point in the stage too, like having just somebody who can really be there and like see your whole self and recognize that like no one piece of this is more important than another, so how can I kind of like support you to make sure that you're taking care of yourself too. Yeah.
I don't think I have really much to add to that. That was great. I wonder if Dr. Sharma, there is any piece that you see that's helpful, when you see patients, either their partner or their other support systems, whether it's, kind of the fertility treatment piece.
Yeah, no, I mean, first of all, thank you both so much for sharing your experience. Like, yes, Sara, I knew about your journey when you moved to the West Coast because I was talking to your doctor and we were talking, but it's nice to hear it in real time and hear the details. And Michaela, thank you so much for sharing as well, because, we're forever learners, and yeah, I don't think I'll ever get to the point where I won't hear an interesting, different way of doing IVF. So thank you for sharing, because it'll help me in my practice for those patients who want to try something different and breastfeed during IVF. So, I mean, it's interesting when I see patients come back for their second child. I'll be honest, most of the time it's only the person who is being transferred, like the mother, like I just full transparency. And is that because everyone's busy now? There's a child, they're familiar with the process. Even for the actual transfer, I find sometimes the majority of the time, actually, it's just the recipient or the mother, because it's like, oh, I've done this, been there, done that. So I would actually say it would be really nice if the partners joined in to hear this conversation, particularly when it comes to making choices about timing of the frozen transfer, pros and cons, breastfeeding throughout, weaning, or anything like that. I think it's important that it should be a joint decision. You're absolutely right. Like, all of this treatment comes with hormonal changes, mood changes, physiologic changes, body changes. And so it's really nice to know that your support person, whoever that is going to be familiar with what's happening. Just a small comment about what you were saying, Michaela, with regards to IVF outcomes while breastfeeding. I actually did a little bit of research right before we got onto this consult, because, I know what the data is in general and how I counsel patients, but I just want to look up what the data is in terms of breastfeeding FETs and non-breastfeeding FETs, and the success rate is actually completely the same. The only thing that's a little bit different is if you are breastfeeding and you stimulate, as you did, there is a small risk of having a lower number of supernumerary embryos. And so in my counseling, and this is obviously separate to the support question that you asked, but I didn't want to miss it, I think in my counseling, again, just like the person who only has one embryo left, for the patient who's maybe 39 with low egg reserve, who's only going to get 4 or 5 eggs, and is thinking about breastfeeding throughout, that could be one embryo less for them, which is going to be important. So that's like a risk benefit that we talk about. Whereas I completely agree, and someone like yourself with a robust ovarian reserve, it probably did not make a huge difference. So yeah, but I think all these decisions require the family unit to be part of, so that you make an informed choice. But I love hearing about, you know, your partners being so supportive. I think that's so amazing. Sara, I have to say that, you know, I'm like a secret Instagram spy, and I follow you on Instagram. So I do see how great your husband is. And I'm sure Michaela, your partner, is too. So they should listen to this video later and like feel really good about themselves.
Yeah, definitely. Thanks for sharing that. You know, I think that's always that main question of like, how is this going to impact our success rates? And I think Michaela really hit it on the head, you know, earlier, in saying we're always kind of 3 steps ahead and thinking about what's next and what if this doesn't work and what are we going to do. So it's always just that balance of gathering information and the right support people around us, and that includes the care team, right? To have those discussions, to look at the evidence, and to, you know, gather information and kind of consider that together. And I think that can be, you know, fertility doctor for those who maybe have questions about the impact on their milk production, on their child, you know, depending on when they're starting this, they can check in with an IBCLC, you know, lactation consultant, their child's health provider. You know, it's always super important to make sure that we're making those informed decisions and that we're supporting ourselves through that, you know, partner, family unit, whoever's around, and hopefully a really good care team. So yeah, and I wonder if there's any other kind of questions to ask your fertility doctor. Like, that was one question that we got. Is there anything that people should consider asking their fertility doctor when they're, you know, when they're thinking about this? Is there anything that comes to mind for you, Dr. Sharma, to start out with?
Yeah, I mean, I think, you know, patients are super empowered now, and they're proactive, and they don't worry, oh my God, what's my doctor going to think? So first and foremost, have a doctor that you can ask any question to, feel like you have a good relationship with them. So choosing your provider is important. I think you both touched upon that. But yeah, like thinking about the number of embryos that you have, thinking about success rates and timeline, looking at your age and how many kids you want. What is your family building plan? What does this look like for you? If this doesn't work out the first time, what are our next steps? I think that whether it's the provider or the patient, we should always be looking 3 steps ahead. And it's not really that next month, that one transfer, that one IVF. It's what does this next few months look like? I really appreciate your talking about the decrease in supply in pregnancy, because, you know, in my mind, you know, lots of people get pregnant naturally while they're breastfeeding, and they continue to breastfeed throughout pregnancy. And so the assumption is that you can do that. But I never really thought about counseling patients about what could happen in the first trimester in terms of their supply going down. So you've actually provided me with some information to talk to patients about, because maybe patients want to continue breastfeeding for like 2 years or whatever, 2.5 years, right? So that's an important point to bring up to patients, as well as the impact of breastfeeding when you have these first trimester considerations like hyperemesis. And it sounds wonderful to breastfeed and give your first child everything and be pregnant, but it could be really tough. And so I think preparing yourself and considering all that is also really important. So thank you for that in terms of being able to discuss that with patients. But these are all great questions that you're providing to the patients now to be able to ask for. But I mean, for myself, I think, and for patients that I see, really it's what supply of embryos do I have? What is my ovarian reserve? What kind of treatments am I looking at? And what is the success rate? And what's my family building plan going to look like? And how far apart do I want to space out my kids safely? And so as the medical professional, we look at the evidence and the data, and we can help you with that, but also help with personal choice and control.
Thank you. Michaela, is there anything else that you kind of have in mind that you wished you would have asked? Or
I don't think so. This has been, I mean, I've learned a lot too, even despite the fact that I've been through it. This has been such an informative and really yeah, really incredible conversation to have. So I'm glad that we've all been able to share our experiences and learn from each other.
Fantastic. Yeah, and I think Michaela needs to jump off soon, and Dr. Sharma was also at the end of a very busy day from knowing what her days look like, being one of her patients. And so maybe we'll just looking at my questions a little bit to see if there's anything that we really missed, but I think that was most of it. I think the only question we sort of got that was a bit more specific to the Leche League and the Leche League leaders is like, what can leaders do to help people? And I think maybe Nikki, I'll start, and if you're a leader as well, if you want to jump in. But one of the things that we always get back to as the Leche League leaders, we're volunteer peer supporters for breastfeeding families, and really all of that, like early parenting, sleep, et cetera, of having little kids, is that we're there to listen and to try to understand what the person is really wanting in the support that they're getting from us. So even for me, I got a question via Nikki a few months ago of someone saying, I'm starting fertility treatments again. Can I have help weaning? And so through a bit of a conversation, the person actually was thrilled to know maybe they didn't have to wean, right? So I think as the Leche League leaders, we're always trying to get to the root of like, what support does the person really want? If they want support weaning, fantastic. We can be there. We can support them through that. If they want information and resources on not having to wean quite yet, maybe on reducing number of feeds, maybe on setting some gentle boundaries around breastfeeding aversions, and even through weaning, having like emotional ups and downs and all of that, right? And so I think those are the main things. And we'll share some of the resources that we mentioned, that Facebook group, the book Adventures in Tandem Nursing, that can really help for leaders to at least be able to point people in the direction of some resources to accompany them.
Just a small point with that, because
yeah.
many of my patients, when they come back, even those that are not maybe thinking about continuing breastfeeding throughout their next journey, I get so many questions about, how do I wean? Mm-hmm. And I always tell patients, I'm kind of the wrong person to ask, because I came back to work fairly quickly. And my journey was probably very different from others. I was like the opposite, where I was like, even if it kills me, I'm going to breastfeed these kids. And it almost did. And I did it. And I managed to get quite far for me. But, I had the work aspect where I came back. And so I always struggle a little bit, because I think patients they struggle so much with, how do I do this? Like, how do I make sure the baby isn't mad at me, like you said? And like, what do I do? Do I drop one feed at a time first? Do I drop and I know from the medical perspective that the night feeds are what are the most important to ovulate. And I always tell them, I said, the night feeds have to go first if you want to get back your cycles. And it's just something about those night feeds that are stronger suppressors of ovulation. So I'm like, if you got to drop those 6 night feeds, otherwise it's not. But then after that, I wish I could refer them to some like hand-holding resource to say, this is how you do it. So I think all those things, if you could share, it would certainly help my patient population, because I will say the majority of them do want to wean then start, like keep it nice and clean and simple. But again, for those that don't, we're flexible. But there's a lot of patients who want to just wean then start, and they don't know where to go and what to do. And most of these people, it's their first child, right?
Yeah, and a lot of people, I think we actually, and this gets into like a slightly different topic, but I think we sort of abandon people on their breastfeeding journey when it comes to weaning. There's so much information about breastfeeding, starting to breastfeed, nursing, like continuing, WHO 2 years plus, like all of this stuff. But there's often not that much about, okay, well, now you've started solids. So often kids are, reducing those feeds, et cetera. But then when you're actually stopping, like, what does that look like? And it can look so different for people. But there's often not a lot of resources until you get into those almost like niche special groups where you find your people to talk to about that. And the Leche League is a resource for that too. And I think some people don't think of that because they think, oh, well, they're about breastfeeding and continuing to breastfeed, but it's really about all of it. So yeah, the Leche League Canada, the website has some wonderful resources and being able to point people to finding a leader in their area. And there's lots of virtual and email support as well. So that can be a really great place for people to go to get that peer support and then be connected to further resources if they need in their local area. Yeah.
Yeah, absolutely, Sarah. You kind of, really nailed it with the Leche League. What we that's it. Yeah, we definitely are there. We've got groups kind of all over, and the virtual group means you can join in your pajamas at home. If
Yep.
you're feeling sick in your bed, that kind of thing is always great too.
Nice.
It's great. And we do within the organization, we do have a professional liaison department. So these are leaders who have a bit more clinical training with lactation and medical information, and they have access to things like Hales and LactMed and other things that they can cross-reference medication and at least offer the resource. This is not, it's not a permission to continue nursing or to wean. This is more, here's the information. You can take this back to your doctor to continue the conversation, especially when you're talking about fertility treatments as well, right? So at least sometimes having information, if you don't have a provider who is, I mean, I hear Dr. Sharma say in the 15 years, it doesn't seem like a long time, but it is a long time, but it's not a long time. How things have changed, in the fertility world with breastfeeding and weaning, and it's been significant for some families, right? And like I hear Michaela talked earlier about wanting to be able to nurse because it's a way to kind of control some of the aspect of that fertility and to be able to bring it back and yeah, so I think I'm so grateful that you were all here today and to hear personal experiences and to hear professional experience and knowledge as well, because this is just I'm very thankful. So I appreciate all of you for doing this and taking the time. And if there was anything you wanted to say before you had to go, any final takeaways or thoughts, now that spring's here.
Thanks again to you both. And yeah, we'll be sure to share this widely and maybe have another event next year.
That would be amazing. That would be. Yes. So
Yeah.
thank you all three of you.
Thanks, Nikki.